All right, I'll go ahead and start the presentation. So today's grand rounds is on the clinical significance of ANA and ANCAs. And I chose this topic because, as you know, in rheumatology, we see lots of patients being referred for positive ANAs, and antibodies are like the biomarkers for diseases, all our rheumatic diseases. But as a clinician, when you order these antibodies, I just wanted you all to know some facts about ANA and some new updates regarding some new antibodies that may help in further distinguishing rheumatic diseases. So some of our facts you may already know, but I just go briefly through it. So what are ANAs? They are anti-nuclear antibodies, but that doesn't mean that they act against only the nuclear antigens. These antibodies may target the antigens in the cytoplasm, in the cell surface, or nucleoli, or anywhere in the cell, but they are in general terms called anti-nuclear antibodies. They usually represent a preclinical stage of autoimmune diseases, and that's why most of the time when there's a clinical suspicion or not knowing what's going on, an ANA is randomly ordered. The most common methods that are used to detect ANAs are the indirect immunofluorescence, ELISA, and multi-bead assays. The other two, ELISAs and multi-bead assays, came into development when immunofluorescence was found to be not very specific. It's a very sensitive method, but not very specific. So in order to improve the specificity, the specific disease marker antibodies, in order to identify them, the multi-bead assays were developed. So what happens is, in indirect immunofluorescence, it's dependent on the lab, on the technician, on how they interpret it. So sometimes it may happen that there are multiple stainings. The nucleus is also staining and the cytoplasm is also staining. But because the staining of the cytoplasm is weaker, they will report it as just nuclear staining or a nuclear pattern. They may not even report any other pattern that is observed. So it is very subjective and is a very poorly standardized method. The reason that it is still a gold standard and needs to be done is because there are a lot of antibodies, autoantibodies to specific diseases, like say Rho antibody against Sjogren's or Jo1 antibodies. Those kind of disease-specific antibodies can sometimes only be detected by immunofluorescence or and not by the multi-bead assays and ELISAs. So immunofluorescence is still done. Their reactivity or the staining just depends on a lot of multiple factors. The substrate that is used, usually we use over here HEP2 cell substrate, which is a human epidermoid cell, like a laryngeal cancer cell line, and that is used as a substrate. The fixation method, secondary antibodies, the microscope, buffers used, everything affects the staining and the detection of these antibodies. So as you can see, it's not a very specific method. And the last thing that needs to be understood is that there has to be an endpoint control for every lab. That means they should have a control of normal population, and 5% of that population at whatever dilution level they turn positive, that should be used as a cutoff value for detecting ANAs. So every lab has their own cutoff value. So our lab over here has a cutoff value of 1:80. So they dilute the serum to 1:80 level, and that produces 5% normal healthy individuals as showing as ANA positive. So that is the cutoff that is different for each lab, and we need to know that for our institution what it is. So there are different patterns that are found on staining, commonly homogeneous nucleolar patterns, but they are not very strongly associated with underlying autoimmune diseases. Just like I said, it's very subjective. Some patterns may be reported, some may not be reported. Sometimes there may be 2 staining patterns in the same individual. And also at different dilution levels, there are different patterns that are observed. So it's not a very reliable way of understanding which autoimmune disease this patient has. Plus, there are a lot of atypical ANA patterns that we see. So what about that? There were articles on it, studies done on the atypical ANA patterns, and they were not found to be related or correlating with any specific autoimmune diseases. So I looked at this one study. It was a study done with multiple labs, 15 different labs, multi-center study, and they saw that as the dilution level increased, the percentage of patients who were ANA positive, that also changes. So 31.7% normal individuals were ANA positive at 1:40 dilution, and as that increased, the percentage decreased. But when they looked at the lupus patient subcategory, all the 95% patients in that lupus group were positive at 1:160 dilution. So it was thought that maybe that would be clinically significant to keep it as a cutoff value, where less than that ANAs may not be considered as significant because they're also prevalent in healthy population, and 1:160 would be help in distinguishing between normal population ANA and autoimmune rheumatic disease related ANA. So this is just based on different studies that were done, and the conclusion was drawn that maybe we should consider 1:160 as a good cutoff value. But that does not mean that a patient who has, or a subject who has a low titer, say 1:80, but has all the other clinical features, then is still considered of value. So this is just relative to each subject, and that is why it is very important to know the clinical features or the clinical hallmarks of the patient rather than just going by the titer of ANA. And that's why the basic recommendations, like we all do, is assess the patient by history, physical, usual labs, consider other etiologies for that positive ANA. As you know, ANA can be caused by infections. It can also occur in elderly patients and is found to be more prevalent in the elderly patients. Autoimmune diseases like hypothyroidism or autoimmune hepatitis, all of those can give positive ANAs. So it's important to do some basic workup before considering that this is all related to rheumatology or rheumatic diseases. So because it's such an important component in the triage and diagnosis of possible systemic autoimmune rheumatic diseases, if we do not look at the proper clinical framework, we will yield a lot of sizable proportion of ANAs and of positive ANAs and not know what to do with them. So this kind of started off a thought that is there a ANA, something like a benign ANA, which is not related to any rheumatic disease? Does that occur? Because we do know that it's prevalent in healthy population. So just to give a little background about it, even the American College of Rheumatology came out with this choose wisely questions. And the top one was don't test ANA sub-serologies without a positive ANA and clinical suspicion of immune-mediated disease. So just to give an idea, I keep talking about that ANA is prevalent in normal, healthy individuals, but how much? This study was done, and it's a relatively newer one, which encompasses the general population, and it analyzed about 5,000 individuals from the NHANES registry. And this was between a period of 1999 to 2004. All the ANAs were assessed by immunofluorescence, and their associations with age, gender, body mass index, and other things like alcohol use, smoking were looked at. They actually found that there's a lower prevalence of ANA in obese subjects, and it was not associated with smoking or alcohol. This table just summarizes that out of these 5,000 patients, 670 were positive. That is like 13.8% is the prevalence of ANA in the general population. Above age 12 to 70, this was the distribution and didn't really show any linear age-related prevalence. It was found to be more in females, more prevalent in females than males, more prevalent in the non-Hispanic blacks, actually, and also in the non-Hispanic whites. So this didn't really show, but the percentage in the non-Hispanic blacks was higher than the non-Hispanic whites. Education and family income to poverty level ratio actually didn't have any effect on the prevalence of ANAs. So now, as you can see, it is very prevalent. So the thoughts came about ANAs, and if we can have a way to distinguish which ANA is related to rheumatic disease and which is not, which is just a benign finding or a random finding, this antibody came into investigation. It's called anti-DFS70, which is diffuse fine speckled antibody with a 70 kilodalton weight, molecular weight. The other name for it is lens epithelial derived growth factor antibody. So this antibody started being investigated because it was found to cause at least 1/3 of positive ANAs in subjects. It is associated with a lot of conditions, chronic inflammatory conditions, cancer, and it was first discovered recently in the 2004 in these patients with atopic dermatitis and interstitial cystitis. And when it was looked at and studied, it was found that it actually is more prevalent in healthy patients and gives them a positive ANA. And the rheumatic, it's not much prevalent in the rheumatic disease patients. So this antibody became of interest to us rheumatologists. And that's how it looks like, very dense, fine, speckled pattern. And again, it has to be confirmed once it's detected, then it has to be confirmed by ELISA and the usual methods. So this study in the Journal of Rheumatology, it looked at the prevalence of this antibody in healthy population, and it was found that 124 healthy patients, when they were looked at, the prevalence was about 8.9%, and these other different disease groups, anywhere from cancer, infections, to some autoimmune diseases, the prevalence was from 0% to 6%. So they were more prevalent, this antibody was more prevalent in the healthy group. So the next study that came out and was looked at was how much of this antibody is prevalent in specific autoimmune diseases. So high concomitance of this disease marker antibodies was looked at in different subgroups of autoimmune rheumatic diseases. So serum samples of 500 patients were looked at, and they were measured by ELISA. And here you can see that these are the different subgroups of the rheumatic disease patients, and out of 500, 22 showed the presence of this antibody, anti-DFS70 antibody. And out of that, the lupus patients, 7 of them had this antibody. So if we look at another slide here, this shows the breakdown of different antibodies, different disease-specific antibodies, which we normally do when we are diagnosing an autoimmune rheumatic disease. Say Sjogren's syndrome, the first one. We look at Rho antibodies, La antibodies, and here, out of the 8 patients, they all had Rho and La antibodies. So they did have other antibodies present besides the anti-DFS70. Lupus patients also, 7 of them were positive for the anti-DFS, but they also had other antibodies like Smith, cardiolipin, Rho, La, and same thing with these other disease, with these systemic scleroderma had the scleroderma 70 antibody, and UCTD, which is undifferentiated connective tissue disease, had the anticentromere antibody. So Morphia, they actually specially did the single-stranded DNA because that is prevalent in Morphia patients. So after they looked at this, they decided to look at just the lupus group by itself and see that did the anti-DFS70 antibody was required to make that diagnosis of lupus or not. So these are the individual 7 patients, and here, as you can see, other antibodies were also present, like double-stranded DNA, cardiolipin, lupus anticoagulant, plus Rho. And then they also had other clinical features like malar rash, photosensitivity, leukopenia. All this was present in these patients along with low complements, hair loss, and other criteria. So basically, all of this means that these patients do not require the ANA as a criteria to fulfill the diagnosis for lupus. They had other antibodies and did not need that positive ANA to be classified as lupus.
Well, didn't you say a few minutes ago that if you don't have a positive ANA, you don't even do these other antibodies?
Well, that is actually a very small component of patients. Most of the time when we are looking for rheumatic diseases, the ANA is ordered anyways. So if the ANA is negative, then we don't even need to go further into this anti-DFS70 and investigate all of that.
So you said if we did ANAs on these people, it would all be positive?
Yeah, so if we did ANAs on these patients and then checked them for the DFS70 antibodies, that was responsible for the positive ANA in these patients. So we are looking to see, because DFS70 is important because it gives a positive ANA to a patient. So how relevant is that? Does that mean the patient has a rheumatic disease? Is it, or it does not have a rheumatic disease? That is the whole goal for this antibody, to help us distinguish that. So here, these patients had ANA positive, and on further analysis, they had the DFS70 antibodies. So we thought that their ANA is coming from that. But do they need it? Do they need that to make the diagnosis of rheumatic disease? So this slide proves that there were so many other clinical criteria present that they did not even require that ANA to be called lupus or Sjogren's or whatever. So DFS70 antibody is not protective. That means it doesn't mean that the patient does not have anything going on or no autoimmune disease at all. It is just accountable for 1/3 of ANA positivity in patients. It is prevalent in ANA positive subjects also with no autoimmune diseases, and it can cause a low titer or a high titer ANA, and it's confirmed by ELISA. So what was suggested or proposed was that if we do ANA by immunofluorescence and we find this diffuse fine speckled pattern, that is the DFS, or any other pattern like homogeneous or combination of these, we go ahead and maybe do the multi-bead assay because we are suspecting autoimmune rheumatic disease in this patient. So we go ahead and do the ANA, we see that pattern, then we go ahead and do the subsets like specific autoantibodies or specific autoantibody markers, and they are all negative. So then the next step would be to look for the DFS70 antibody. If it is positive, that means it is just a benign ANA, and you don't need to worry about it, and no need for rheumatology referral. But if it's negative, then maybe that ANA may hold some significance, and then you could go ahead and consider rheumatology referral. So that was suggested in this last American College of Rheumatology meeting, that asking the labs to see if they can add this on and do this anti-DFS70, so it will help discriminate between a benign ANA or an ANA which is associated with some autoimmune disease. So considering these results, this antibody is autoimmune rheumatic disease patients with just the anti-DFS70 antibody is rare. Usually they will have other multiple disease specific autoantibodies. So recognition of this pattern is important. It can be used as a screening test to exclude, and thus it will have some cost saving potential. So before I go on to the next one, ANCAs, is there anything that I can answer about ANAs? Any questions? So ANAs, ANCAs, they are very common, like commonly ordered, common biomarkers that we use in our clinical practice. We see, so ANCAs is another one. We see patients with rashes, skin rashes, and there's some suspicion of vasculitis, then the ANCAs are also ordered like biomarkers. But do we know how much diagnostic utility they have? Do they have any prognostic utility? Is what I will address in the next few slides. So ANCA is anti-neutrophil cytoplasmic antibodies, and they are directed against the cytoplasmic antigens. And these antigens, the most common ones that are targeted are the PR3, which is the serine proteinase 3, and myeloperoxidase. So depending on their staining pattern, they are classified as C ANCAs and P ANCAs. Cytoplasmic ANCAs give a cytoplasmic staining pattern, and perinuclear ANCA give that kind of staining pattern, P ANCAs. But these are not the only two patterns that are available. There may be several other staining patterns, some atypical patterns also that can be seen, but those two are the most common ones that are used for diagnosis. So now, do these ANCAs help in diagnosis? Can we just look at an ANCA and say that this patient has vasculitis? That actually is not true, because we do need biopsies, and along with the clinical features and everything, then the diagnosis of vasculitis is made. So ANCA is just supportive of the diagnosis. But when clinical trials are conducted, there were some classifications and some definitions that came about to help categorize patients so that we can compare their treatment response and everything else. So these classifications have been in existence. The Chapel Hill Consensus Conference, they provide definition of the disease. They include the size of the vessel, the pathology, and the organ system that's involved. The European Medicine Agency came about, they improved that classification system a little bit and added the ACR criteria, the American College of Rheumatology criteria, included the ANCAs and just modified it a little bit. And then the American College of Rheumatology criteria included some clinical features and biopsy as their criteria for diagnosis. But all these categories, they define the disease. Which one would you call as Wegener's? Which one would you call as Schurg-Strauss? Which one would you call as microscopic polyangiitis based on the presence or absence of granulomas? But can we distinguish these diseases by the ANCA types is what the question was raised. And it was shown, like in the next few slides, some studies were done, and it was found that the ANCAs do help in categorizing the disease, and maybe they are a little bit more better in predicting some things that the other classifications did not help in. So once we look at the clinical picture of a patient, we see what the pretest probability is of the patient having the disease, Wegener's or granulomatosis polyangiitis. We should know the assay that is used, because again here the indirect immunofluorescent assay is used, and it is not very specific, so confirmation has to be done with ELISA for the specific antigens, like is it targeting PR3 or is it targeting MPO. And when we see the combination C ANCA with PR3, MPO with P ANCA, then it has more predictive value for that particular vasculitis. So C-ANCA with PR3 has a more positive predictive value for granulomatosis polyangiitis, which is the other name for Wegener's. And P-ANCA with MPO is associated with renal limited vasculitis and microscopic polyangiitis. But this P-ANCA is very fickle. It is found in a lot of other conditions. It can be interfered by the presence of ANAs, and we also find these antibodies in a lot of other conditions like bacterial endocarditis. It is actually associated with the development of C-ANCAs and the PR3. So this combination actually has a very high 80% predictive value for Wegener's, but it can also be found in bacterial endocarditis. So these things need to be ruled out first. ANCAs can be formed by different drugs like hydralazine, propylthiouracil, and minocycline. And the latest has been going on now is this levamisole contaminated, the cocaine contaminated with levamisole is also inducing the formation of ANCAs, atypical ANCA patterns, and also the clinical picture is also like vasculitis. They can affect the kidneys, they can cause glomerulonephritis, skin rashes, and the picture may just look like a vasculitis patient. So these are all vasculitis mimics which have to be kept in mind. And they also tell you that ANCAs are not, they are not the sole criteria for diagnosis of vasculitis. They are supportive, but they are not the sole criteria. So C-ANCAs can also be found in cystic fibrosis, and P-ANCAs have been associated with inflammatory bowel diseases. And atypical ANCA patterns, when you see that, they are directed against various antigens, elastase, lysozyme, lactoferrin, so they may just give you different patterns. And sometimes you may see both PR3 and MPO present in the same patient. When you see that, then suspect drug-induced vasculitis or drug-induced ANCA production. So these diseases, GPA is the other name for Wegener's, and microscopic polyangiitis. What's the difference between the two? It's only the presence and absence of granulomas. GPA has the presence of granulomas, and MPA is more necrotizing vasculitis presence. ENT inflammation will sometimes serve as a surrogate marker in differentiating them, but most of the things are common in GPA and MPA, so you cannot really separate them on clinical grounds. You need something more, and that's where the ANCAs come into use, that they will help in defining the disease phenotype of these patients. MPA, you see P-ANCAs more commonly, and GPA you see C-ANCAs with the PR3 combination more commonly. So once we get the ANCAs, what other things does it help us with? It does help us in categorizing the diseases, Wegener's versus microscopic polyangiitis, but it also helps us in other things like defining or understanding the organ involvement disease by the ANCA specificity. So if you look at the end of the slide, you can see that if there is more destruction, bone destructive diseases like the nasal saddle deformities and the nasal ulcers, crusting, the prevalence of PR3 ANCA is higher. And in more renal limited diseases like ANCA glomerulonephritis, there is higher prevalence of MPO ANCAs. In between they kind of overlap, but here in the beginning and the end you can see how the prevalence is different. So they also help in categorizing and defining the disease phenotype of this patient. This is just a summary of what I said, that they do help in distinguishing the disease types. They help in categorizing when the pretest probability is high. They do help in understanding the organ involvement of the disease. But the next question is, do they actually help in prognosis? If that is the case, then why don't we use the ANCA-associated vasculitis as a more common classification, because they seem to be more useful if you define patients by the presence of ANCAs rather than by the term like Wegener's, etc. So Leonaki addressed that question. He looked at some patients and classified them according to the classification system. So CHCC was that one classification, Chapel Hill classification. Second was that EMA. And third, he used the classification where only the ANCAs are used to group a patient. And then he looked at their outcome for treatment resistance, relapse, end-stage renal disease, and death. So here in this article, 500 patients were looked at. Out of that, 483 had treatment resistance, and the numbers over here are, as you can see, under the Chapel Hill classification, this is GPA, microscopic polyangiitis, kidney-limited disease. They all three were classified. European had these two as their classification or the disease groups, and the ANCA specificity patients were grouped as MPO or PR3. So when you look at this, the trend across here in each of these disease types is different, but the significant one is over here, where the trend for treatment resistance was seen more in the MPO ANCA group than in the PR3 group. Over here, the kidney-limited disease had more treatment resistance than the Wegener's group or the microscopic polyangiitis group. So there was like this classification helped more or had more p-value. P-value was more significant than these two other classifications. For relapse, when relapses were looked at, the PR3 ANCAs had significantly more relapses than the MPO group of patients. And here in the Chapel Hill classification, the Wegener's group had the highest number of relapses. So the significant, as you can see, the trend towards the ANCAs were more helpful. Like this classification helped more than the rest. And there were some trends noted over here for end-stage renal disease and death too. This was further looked into detail, and this table shows that when these diseases, the kidney-limited disease, microscopic polyangiitis, and Wegener's, when they were grouped together and looked at by the presence of ANCA, it was found that the ones that had the PR3 ANCAs had almost twice the hazard ratio as compared to the MPOs. So this shows that the patients who have PR3 ANCAs, they tend to have more treatment, tend to have more number of relapses than the patients with MPO group or with the MPO ANCA. And this kind of shows the same thing in a graph form, that the group with the renal limited disease, microscopic, and Wegener's, this is showing the PR3. And this is showing the MPO ANCA levels, and the probability of relapse-free survival was shorter for the PR3 group. So in all of these, it's the same. So basically, PR3 ANCAs do have some prognostic utility. They help in defining the relapses, like they tend to have more relapses than the other groups, and they tend to have shorter relapse-free survival time also compared to the MPO group. So this was more beneficial when the ANCAs were used as to classify or group a patient. They also have different genetic associations than MPO. They are found in different regions, like PR3 GPA is more common in Northern Europe, and MPO is seen more with P-ANCA in Japanese patients. So what they also looked at was that since ANCAs are now helping in diagnosis and some in prognostic, they have prognostic utility as well, do they have any difference in response to treatment? So when the RAVE trial was conducted, which was actually a trial where they looked at rituximab versus cyclophosphamide for the treatment of granulomatosis polyangiitis, they found that they were non-inferior to each other. Like rituximab was as good as cyclophosphamide for inducing remission. So in those subjects, they looked, when they subgrouped them in the post-hoc analysis, they found that the patients who had the PR3 ANCAs were responding better to rituximab than cyclophosphamide. So again, in summary, they do have diagnostic utility, but you need to know the methods that are used and how much is the pre-test probability of that patient having Wegener's or microscopic polyangiitis. They do have prognostic utility. They can be a biomarker for disease phenotype. They also help give you some idea about the treatment response, and they are a biomarker for relapse risk as well. So once we know that question is addressed, that ANCAs are important and they have value, even though they may not be the sole antibodies or the sole criteria used for diagnosis, if we monitor these patients after remission, do they have any value? Do their titers have any value? Increasing titers and decreasing titers, do they hold any significance? So this has been a question since the time ANCAs were discovered and their utility was known. And a lot of meta-analysis have been done, and the conclusion is that they could not reach any consensus about these titers because every study used different definitions for the ANCA rise. They used different definitions for remission and relapse. Methodology that was used was different, and testing intervals were different, so no consensus was reached. And basically, right now the conclusion is that serial ANCA monitoring does not really help in defining whether this patient will relapse or not, or whether this patient will stay in remission or not. And to address this question, it was revisited recently in that RAVE trial, and it's published in New England Journal of Medicine, that when they just looked at the subgroup in a supplemental index, they gave a small table showing that they did not find that increase in ANA titers really predicted relapse. So here you can see the ANA titer increase. The cutoff was 20 units, so if they doubled up, it was considered as a titer increase. And if it was a negative value, that means that there was less than 50% increase in that patient's ANCA levels. So titer increase, really number of severe relapses versus limited relapse and no relapse, it wasn't very high. And same thing in the cyclophosphamide group, the number of severe relapses was 8 and no relapse in 18 patients. So this increase in ANA titer really was not significant. And the patients who were ANA negative, also one of them had a severe relapse here in the rituximab group and in the cyclophosphamide group. So the conclusion drawn from this was the increasing titer does not really have much value, but the absence of ANCA is helpful in kind of deciding whether this patient may not relapse or may stay in remission, because only one patient had a very severe relapse with negative ANCA. So absence of ANCAs are more valuable than the rise in the titer of ANCAs. So in summary, this about ANAs and ANCAs, they are helpful biomarkers, but in ANAs, like I said, we just have to know that how widely prevalent they are, and then use it in perspective, with the clinical perspective. Similarly with ANCAs, they do have diagnostic utility, but the specific ANCA type will actually, it does help in defining relapse risk, disease phenotype, and also give some idea about treatment response to rituximab. So I would say that after looking at the clinical picture, then deciding how much value that ANA has or ANCAs have is more important than just having like a random value of ANCA and no clinical background with that. And this is the summary about ANCAs and ANAs. So any questions about that?
Dr. Seth Burney hated ANCAs.
Yeah.
He used to get very angry if we ordered ANCAs, but we still ordered them, you know.
Yeah.
Despite his anger. Why was that? Why did he not?
It's because, like I said, it's present in so many other conditions like cystic fibrosis, endocarditis, and now it's being found more and more in inflammatory bowel diseases too. So we still need the biopsy to say this is vasculitis. And ANCAs will be supportive of that diagnosis. So if we are thinking clinically this could be vasculitis, and the picture is looking like that, then getting ANCAs is okay because it will support that diagnosis. But just with not much of clinical features present and just doing a ANCA will not really, give us any clues.
So usually we order ANCAs with RPG. When we suspect the creatinine is going up by 0.3 to 0.5 every day, and we've got some proteinuria and hemophilia. So we recently had a patient had hemoptysis, lung infiltrates, had a nephritic syndrome, and the creatinine was good. And they had initiated therapy, and the ANCA was positive.
Okay.
And some people came to me and said, does this patient need a biopsy? I still think the patient needs a biopsy. Because you can't just go on the ANCA. It could be something else.
Yes.
You need
which ANCA was it?
I don't recall exactly. But I strongly said that the patient needs, and the biopsy did show exactly what we had suspected. The patient did have mesenteric GN, and a necrotizing lesions.
Yeah.
But I still feel that a biopsy is needed, either a lung biopsy or a kidney biopsy.
That's
You agree?
That definitely.
Because you could
That's why all of these ANCAs, they do help in some way. They support the diagnosis. And they may have some prognostically, this patient has kidney limited disease. If it was PR3, then it would need closer follow-up, closer attention because they may have a higher risk of relapse. So in that way, they help and support, but not just for pure, not isolatedly, they cannot help in diagnosis.
Rheumatologist anger comes because once the antibody will check when treatments are started without getting biopsy, then it's really hard to go back in retrospect and try to get things the right way. So I think that's why we keep saying that ANCA should be checked only when the pattern is there. And the patient you're describing has a right pattern to get ANCA checked with hemoptysis, with lung infiltrate.
Because the clinical picture suggests that.
But I do believe that if you have a very strong suspicion that this is pulmonary renal syndrome and the patient does not have a pneumonia, that you should start therapy very early and not wait for results of biopsy and so on, because these are very bad diseases, and especially the creatinine is once it's 4 and it moves above that, the likelihood of this saving the kidneys is very low.
Yeah.
So I think most people agree that if you have a strong suspicion, and this will happen on a weekend sometimes, because you don't have all the services, unless you insist on getting a biopsy on a Sunday or a Saturday. I think it's best to start therapy.
So that would include steroids, but not the immunosuppression with chemotherapy too. We have another
And
tissue bag.
in fact, there was a board review question in nephrology where they included plasmapheresis, and the correct answer was steroids plus plasmapheresis. And I thought that I would just give steroids and not start plasmapheresis.
The slide indicated PTU gives you a false positive ANCA. Is that correct?
PTU?
PTU.
No, it gives an atypical staining pattern of ANCA. So it's false positive, not really false positive, it's just that the staining pattern is not PR3 It may not be MPO either. It may just be against elastase or some other antigen. So
Be positive.
Okay, so is there a PTU-induced vasculitis associated with positive ANCA? Because that's been my understanding. It's very rare.
yes.
Okay.
I mean, there is, it does exist. We had a patient with hydralazine-induced vasculitis, drug-induced vasculitis with a atypical ANCA. But yes, it does exist. And similarly, and that's why we need biopsies, to rule out these other entities, because cocaine, like I said, with the levamisole also gives a very clinical picture of vasculitis with glomerulonephritis and rashes and everything. I haven't read about any lung involvement, pulmonary hemorrhage, but that's why that patient would need a biopsy to confirm, what it is. And removal of the drug is the treatment. And while the other disease entities will need a whole 6 months of, immunosuppression and everything else, while these agents may not require that long, and then the remission and relapses, everything is different.
So to channel Dr. Murray for a moment, if you're going to say you need a biopsy, and you've got a biopsy, is there any way not ordering an ANCA is going to hurt the patient? Is there something you're going to get from it that's going to make you trump the biopsy?
I would still get it just to know the prognosis. So if this patient has Wegener's or say microscopic polyangiitis, on biopsy, then I would just get the ANCAs just to see if they are PR3 positive or MPO, and kind of have it in my mind that they may respond better or they may relapse more frequently, and I just need to follow them more closely. So I would probably do that for that aspect, but not for diagnosis, not for therapy. No. Therapy is the same between, and there has been no differences found between the two groups for remission induction and everything.
Because that was my impression of why Dr. Bernie was against it. He's saying, get your biopsy first and then decide if you want it, instead of doing it the other way around.
Yeah.
It takes time to get the ANCA because it usually goes to a reference lab, and biopsies you can get the next day, the report. So if you do the biopsy today in the morning, the pathologist here can show you.
That's true. Our lab is actually doing we have to request them to do the PR3 and MPO. They do that separately, and the ANCAs are done separately. So
They do it here now.
they do it.
In the past, they used to send it out.
Yeah, so PR3 may be a reference lab still. I'm not sure. Is it still a reference lab, PR3 and MPO? Yeah.
Yes.
So, but they do that. We have to request it separately. So just having a C ANCA, P ANCA is of no value till we know which antigen is targeting, because that's where these studies help out, as far as treatment resistance and all that is concerned. Any other questions?